It is in two parts. First will be we talking about the pseudo sciatica, which I just mentioned. Second is the real sciatica and how can we best manage the real sciatica, be it pre-surgically or after surgery for that matter. So that is how it's going to be. But understanding is very important, that if you don't really know the problem, the pathophysiology of the pain, how can we go to treat the pain effectively? That's most important to realize. And there can be a different contributors to the given pain on the part of the patient. It's not purely all disc, it's not purely all root, it's not purely all facet. They can be combo, and we have to treat them all, because if we look at the MRI report, there are multiple things which are reported and they all can be contributing in 5, 10, 50, 20% of the way. So we have to treat them all in simultaneous way. So this is about the diseases. They can be something to do with the myofascial stuff which I have removed off. They can be Lick-Rest syndrome. They can be ligaments all around. Then they can be facet. Then they can be SI joint. When we'll talk about it, then we're going to talk about the hip syndrome. We're going to talk about the ischial-tuberosity syndrome or hamstring syndrome, and then further on knee and then ankle, which has been beautifully told. And that is what it is. Now, understanding the pain at the part of the disc, it has been talked again. This is another time which is there, and the new thing which has come is the sinovertebral meningeal recurrent meningeal nerve, which is causing pain. Many people are doing a targeted intervention on this nerve, which is causing the pain. And believe me, because it is supplying the outer annular fibers and the PLL, you can really take care of that pain part, because doing something inside the disc is not always great for the pain part. I would request everybody to be on silent mode, please, so people can maximize. And then other one is, which is there is, if you look at this part, sometimes anterior disc syndrome, which is there, which is mediated by the autonomic nervous system sympathetic chain, that can be addressed. Yeah, silent please. That can be addressed by the sympathetic chain block, because see, a chronic disease, it has got anterior component also, which is more of a visceral kind of pain. So it's not like typical pain which is coming from the nerves. Friends, please, I request again, please be silent. Now, this is a very important slide. It says the most of the pain generator, more than 90% are A delta and C fibers, are coming from the anterior epidural space, and they are the one which are supplying the PLL and the annulus. And posteriorly, there is nothing much which you need to do. So what we have to address is the anteriorly. When we are trying to do posterior epidural, it does not really address the pain in a many number of patients until there is a festogenic pain, right? And so that's why we are trying to do anterior epidural injections most of the time. This is another reason which I said we sometimes tend to do a sympathetic block for same reason when there is anterior discogenic pain, which is more of somatic or sympathetic chain mediated. Now this is a dirt, you can see the disc coming and the root is getting compressed from all compartments, anterior disc, posterior capsule, and the collapsing the disc space, and the root getting impinged, the poor root is getting trapped in there. This slide is from Professor Young and is beautifully telling what all could be the reason for a pain at the facial region, when in the foraminal region. It says it can be inflamed disc, it can be hypervascular structures around there in the axilla, then can be a hypertrophied SAP, tender capsule, the impacting facet margins could be there, and which Professor Gore tells very often, if it goes above the lower margin of the upper vertebra, you're looking for a trap. And the superior foraminal osteophytes, which is there, which is kind of calcified there, or superior foraminal ligaments there. There are many ligaments which is seen now in the foramen, and they can be entrapping the nerve. And nerve once get entrapped, gets painful, more edematous. That's why it's get more inflamed. That's why we try to give a steroid injection. It gives a good relief, yes, diagnostically as well as therapeutically. That's the important thing. And then there are hidden osteophytes which is there in the shoulder, which can be reason for pain. There are other generators which I'm not going to enumerate, but there are so many of them around which can be reason for the pain in a given patient. Now this is a true sciatica. I'm going to come to the pseudo sciatica again. And then we have been doing, so many pain guys are doing so many things in interventional way. Well, it may relieve in some patients, but many patients would need some higher intervention, and let's talk about that. And then we just do a very good disc removal, which I show very often, and you see the exiting, the traversing root and the dura is all cleared. Still, the word is, in spite of that beautiful decompressive surgery where there's a flapping root is there, which is very, very clear, patient can still be having some problem. Now, what is it all about? It can be a fibrosis in here, there can be a recurrent fragments, and there can be some festogenic syndrome, or there can be a facetal traps. And then we're going to talk about it. And what is said is, many times we try to do an MRI, it does not really pick up those problems. So we might have to go in and do a diagnostic block. We have to do a clinical test, examinations and history, and then go out with the diagnostic block after MRI and other thing which needs to be done, and then only we'll come to know 100% what exactly is the problem. Look at this patient. You don't recommend a disc surgery straightforward in such patients. That's the point. So, but patient has got a multiple factorial problem. Lot of bad festogenic pain, some entrapment is going on, as lateral stenosis is going on, but not per se discal fragment. But yes, we can discuss, we can do a little canal decompression, which Professor Gore and other people are teaching, and is a very, very effective method. But remember, still there can be a festogenic pain in given patient. So that needs to be addressed, that needs to be seen. Other thing which can mimic the sciatic pain is the facet syndrome, which I just mentioned you, the radicular pain as it is, which is part of the sciatic, and SIJ syndrome, and the other ones which is going to come, which I mentioned you. Now, this patient has been done a beautiful disc surgery, great, but patient is still burning there. Look at this, she's got a pain coming. This post-surgical syndrome we see very, very often. We have to address, see, that's what Professor Gore and other people said of pain is a pain is a pain. Patient doesn't know what is the problem. Patient don't know what kind of surgery you've done. Patient is interested in only one thing, that is his pain. So if you don't take care of his pain, obviously it's going to be a problem for the on part of the patient and you too. So both are going to be haunting. There can be a what you call inclination syndrome or stresses because of the misalignments. Maybe it's above the spine or below the spine. We have to look at facet traps are there. We know it all. And yes, there we have a wet facet. You will see beautifully. These are the one which actually it should be taken up for surgery. But there may be situations which doesn't warrant surgery or patient doesn't want it. In those patients, you can go ahead and do some intervention, which I'm just trying to label is like we do an intra-articular, which here. But lately it is said, don't go intra-articular unless you're going to put a PRP inside the joint. So inside joint, you don't put steroid because it can damage cartilage all the more. So you can do peri-articular steroid or a PRP or you intra-articular the PRP. Some people are still doing steroid, but it's not really advocated much. But more important is when you do a fester nerve, you try to kind of give an LA in there, which has got a higher diagnostic value. And further on, when you do an RF, that is the mainstay of the treatment. The gold standard of this is the RF of the facet nerve, which can be a conventional RF or a cool RF. Cool RF has got a bigger lesion, so it doesn't miss on the nerve. That's the whole point. For one joint, you take two nerves, the nerve at level and nerve from above. You see the branches coming from above. The two nerves have to get taken for one level, at level and above, always. Except L5S1, we have to take one below also. This is the study which is there, which is lately a lot of people are doing work on regenerative medicine. They see the crossover is after 2 months, the PRP is doing better than the steroids. See, initially steroid could be looking more rosy, but we have to see long term. We have to, patient has to follow with us. This is about all the regenerative medicine in the disc disease. The closed disc disease, which is painful disc, discogenic pain, without bigger bulge, without big annular tear. There they have done studies with the stem cells as well as the PRP and combined them. They found it to be very, very useful. So we are in age of a regenerative medicine and now they are already getting into the gene therapy. This is going to come. This is going to come. Before the disc tears open and presses, then this all is a non-surgical way and it's a very effective way. Don't leave patient in pain. That's the whole point. There are so many good modalities. All those annuloplasties and everything can well be done. Now this is about the facial denervation. It can be done on ultrasound way. Yes, if you don't want radiation, that can still be done. There's a beautiful thing which is coming is a fusion. So you have all those ultrasound images, CT images, they give a fusion of this and you can almost get a navigation like picture and you can take your needle in there and just burn the nerve. You have to be accurate in your work, only then it is result oriented. Otherwise you lose the effect and patient comes back. See, in our practice, the straightforward gauge is pain. If patient says pain is pain, otherwise it's okay. What kind of person you are, it is told by the patient. Now this is what we are trying to say. The nerve comes under membrane ligament, supplies the joint. One has to understand. And about the L5S1 I mentioned you, one above at level and one coming from below, two coming from below S1, that needs to be addressed. This is how we are trying to place parallel to the nerve under the membrane ligament and burn the nerve. Why it's important to talk? We may do it before surgery or after surgery, and I try to combine with the endo surgeries if I do at all or in this procedure, because I don't want patient to come back with a festogenic pain. Important fact is, after this procedure, there is a disc collapse syndrome. More the disc collapses, more is the facial loading, more is the pain. So you always preempt it and kind of treat it beforehand, and this is what I normally do with all these patients. This is, by the way, post-surgical, which you see very often. We do a RF and his pain is taken care of because patient has got a local pain. Patient doesn't have a leg pain at this point of time. Yes, synovitis everybody knows. You can manage non-surgically to begin with and give a trial, but anyway, surgery is the best option for these patients and it's very, very rewarding, by the way. Yes, there would be few patients who got a pars fracture. They will mimic like a sciatic leg syndrome and bones can pick up. No, nothing else sometimes picks up, and then you can go and do your needful there, and it's effective RF at the pars, which can do. Another is the transition vertebra. I've seen many such patients, 2 to 5% patients, and more so post-surgically, as I mentioned you, because more it collapses this one, more is the pain coming up from here. And you have patients which has got a no disc disease can still have a transition vertebra pain, which mimics posteriorly in the thigh, posterior in the leg. More so when patient lies in the bed, and that is the time we go and put in a drug there and do an RF. Coccygeal pain, beautifully told, which is the pain of the tail, nerve of the tail, and that's what you do is a impar block. You may do a neurolysis, RF, and obviously I add on, I do coccygeal nerve RF. It gives a very, very good response in these subset of patients. Very good response. Don't lose on these patients. They are your bread and butter. They give you 100% response. This patient has been, is no surgery, by the way. He's got a pain in here. There's more of a SI kind of pain. Sometimes L5 and SI. And this is the SI joint pain distribution. You have all those provocative tests. You try to do them, find out. And then you have SI joint injection. This is diagnostic one. So not always you get this kind of picture there. But yes, it is good in inflammatory one. And lately in India, tubercular patients also, infective patients also, they come. You can always give them pain relief. You cannot give them steroid. Inflammatory, you can give them steroid. In other patients with the infective, you can do a blocks, the nerve blocks, sacral nerve blocks, but no intra-articular steroids. And these patients can be held, and it can happen after pregnancy also, means just post-delivery. And these patients, they come and you give one shot is more than enough. You don't have to do something more. And this is how it has been done, and gives a good relief, and it takes about 1 to 2 ml of injection. It can very well be done ultrasound way, especially in the pregnant ladies if they have pain, and you can just put a needle coming from medial to lateral and just put a needle in there. That's it. And this is about the SI joint RF. Lately speaking, this is the nerves are coming out from here. S1 is the main contributor, S2 also, and you 1, 2, 3 nerves, because they are multi-depth branches and multi-branches. They all are kind of not in one place. So what people do is they do a multiple RF around the foramina S1, S2, and sometime in S3 foramina 2 blocks in there, and definitely have to take 1 block at the L5, sometime even L4. It gives a good response. Cool RF has got a bigger lesion because you don't miss on the nerve, but keep in mind that you shouldn't burn the skin. This is piriformis syndrome, and you can see sciatica, pseudo-sciatica, nothing big difference in here. This sciatic nerve and this piriformis, if it's causing an issue, it is pseudo-sciatica, which will present like sciatica again. And you have to understand, because otherwise you will fail. When you get an MRI done, many people, 33% patients will have a MRI finding of a disc disease. That does not mean that this is the one which is causing problem. So that's where you have to really address it beforehand. You do a sciatic nerve steroid or Botox, it gives a good response. Sorry, not sciatic, the piriformis, it gives a good response. There are some patients who have got a cluneal nerve syndrome. Not many people talk about it, you don't know about it. Or I call it sometimes iliac crest syndrome. The iliac crest, there is entrapment going on, and it's a real known entity, by the way. These are cluneal nerve, which are the dorsal branches of all these lumbar nerves, and there is entrapment going on. So if people do an open surgery, we don't have to. We do ultrasound guided way, we can just give them a block there, and this works great. Not to forget, many people will have some hip pathologies, which may still present, patients not able to walk, and we are still taking it as a sciatic pain. So one has to understand, and more so when there is a lateral hip syndrome. Many people will get it, especially post-surgery, when they're lying in bed for a week or two, especially in corona times and other times, and more people resting on the sides, and more and more of them happen. Put a thumb on the greater trochanter, and patient will be jump sign. And then you can just put a probe in there, ultrasound probe, and go inside, put in a single injection. Works simply great. This is steroid normally, but if it is degenerative, you can think of putting in a PRP. And this is lateral protein of thigh. Not many people talk, but this is again one of those anterior thigh, anterolateral thigh tingling kind of thing, which works great. And in this webinar days, we people also started getting lateral protein of thigh pain. And this is about the knee pain, posterior knee pain. I'm going to talk about posterior, but just because this is a beautiful picture showing genicular nerves distribution, very good paper. So what I was trying to say is a Baker cyst or posterior knee pain or posterior capsular, posterior meniscus pain. I've seen people coming with a posterior knee disease presenting as sciatica. So you have to be very, very careful on those accounts. And if you treat this thing, you might have to send them to a knee workup first, and then you take up the spine if need be. Like Dr. Gore and Dr. Pawan team is doing, they are doing a combo. The medial knee, hemi, meniscectomy and other things, hemiarthroplasty along with the spine is perfectly poised, because patient has got a problem. Patient will come with a bigger problem of spine later on, so it can well be addressed both together. So why not? Don't leave the patient in a problem. 4-6 months for spine, 4-6 months for knee, you can combo them, and they save on time, and one life to live maximized. This is the mainstay of talk, what to do with the true sciatic pain. and this is what true sciatic pain will present. The roots are causing, now it's a radicular pain. When you talk true sciatic, radicular pain, we got many epidural approaches coming from the caudal with interlaminar or foraminal approaches, and this is one of this nice slide which tells how we address the L4-5. We just go in there, and this is the root which is exited, and this is the one which is L5-S1, which you don't see from here. You do a cephalic tilt of the C-arm, and then you start getting the L5, and you start putting a needle in there. It is for intradiscal procedure as well as for this. Don't forget the S1 root. Very often L5-S1 disc, which is the central disc, which has a problem with the S1, and you have to target in here, and you will get some slides coming in here. This is the entrapment. This is the now normal root, and this is the entrapped root. You know, just few slides, just two thought-provoking slides, and I like those slides for same reason. This is what we see, the safe triangle, many times in our earlier practices. This is really unsafe, and this is the one which is safer triangle, which is the Camber's triangle, and this is the DRG we are talking, and we are dealing with the cord and not the cord, by the way. And this is the Camber's thing. Many times I put this slide for one reason. There is rami communicantis. If it's anterior disc syndrome or little disc syndrome or anterior, then you either have to block this or rami. It works great. And this is what we are talking about, the safe triangle approach, and this is the Camber's triangle approach for the root blocks. Same thing is shown again in slides. And this is now this is about the root block. We're coming at the root block, right on the root. Now this approach is used when we have to do pulse RF of the root, sitting on the root. Otherwise you try to sit here in the Camber's. This slide is I'm showing especially for the idea what is Camber's triangle is all about in a one dimension. Otherwise a Campbell pyramid, which was taught last time by sir, in a three-dimensional way. And this beautiful slide tells your 95% time your vessel will be around in this unsafe triangle. Don't try to go in there. You try to reach from the Camber's triangle, and that's where you get the best address. And most importantly, you're going to take care of the disco-radicular conflict in this area. This is about the arteries, small arteries, which will become radicular arteries in the due course of time. And they come by the side of the root, and they just get into the cord there. And this is when you inject any steroid. It's a nasty thing. And that's what is happening. This artery, if you put in by the side of root, this is what you're going to do, root block many times. And if it can go across, then it can cause these are end arteries, and it's cause a permanent damage. You're lucky if you get out of it after injecting. This is what we normally try to do it. The safety point is, because when they do a subsection angiography, they found the vessels are going into the spinal cord, these small arteries. You have to be very wary of these arteries, and only in high-end C-arms you can find them. So it's always good to stay retroneural. When you say retroneural, the vessel is coming from here, is getting into by hugging the artery, hugging the vertebra, so you can be safe about it. Otherwise it is a problem. Or you come in Campbell's, as simple. Why go there and do an injection there when your problem is here? When your problem is here, you put your drug, concentrated low volume drug, which is just put in there. Why waste the drug up till there? There's no pathology there. So that's the whole idea, is putting concentrated drug in there, because that will address the exiting and the traversing both. And that's the whole idea. This is about the S1 which I mentioned earlier. Many times L5-S1 disc will cause S1 problem. You put in a drug there. If it is not addressing L5, go and put in L5 also. Or other way around, you put L5. If it's not addressing S1, then you come to S1 also. This is one of the very latest findings from the Cleveland Clinic. They found this is as effective as a root block. When you do a lateral interlaminar epidural, you go inside there, you put your drug in there, and it works as good. This is, by the way, I put an extra dye just to show people how it looks like. Otherwise, you might have put just this much drug, that's more than enough. And that is coming from posteriorly. The whole idea of this slide is, when there's a posterior element problem, like more of a histogenic problem, then you address this. If more of a discogenic problem, anterior epidural space problem, you come the foraminal way. This is the caudal neuroplasty, and we see a nice Christmas tree. But if you don't see, if there is a halo effect, then you put in a catheter there, and it's a very nice technique from Rax, and then you go and address the nerve. You L5, S1, these are the catheters which can really break open the adhesions. They are cannulated catheters. You can put drug through this, put in dye through this, and you can really see well. For some reason, if you're not able to see this, you can always join it from the side. Like this is not showing up. I'm trying to put as much drug, everything is going this side. You can see all roots, nothing is shown on this side. Either this is the septum, which is you can see very well now here, or you might have to come from the other side and you can address your problem. Sometime it is needed, it can be done in cervical. This post-surgery, remember, this post-surgical syndrome is a rescue kind of scenarios. And you keep seeing, this is the Union Cabinet Minister, long time back, 2009, I did this procedure. He has had a surgery, it's okay. Surgery is in best of hands from AIMS, by the way, in best of surgeons, HOD AIMS, but still patient can have problem because there are other allied things. So we have to look at the bigger picture, not just the pain, the whole scenario altogether. But remember, when you talk about this environment, if you take care of this, everything goes off. That's the beauty of it. It's like a dark, we put a light on everything, everything becomes enlightened. The failed back surgery, or we call it a post-surgical syndrome in true sense, there's so many other things which could be involved. If we keep a count of them beforehand, we don't land into the failed wala scenario, and we can do justice to these patients. Now this is another patient who has done a good nice fixation. She's got an upper problem, which I showed you, the burn back, and you can give relief, but there might be reason that you go ahead with the further surgery on. But the problem is transition syndrome is going to be there. More you fix, more is the problem. So this is another patient who's got a 9-level fix kind of scenarios with the artificial disc in place. Now this area is in problem. If I give you history, she was done surgery, she had the CSF seroma, and she was operated for CSF seroma. She was on ventilator for 20 days. So the old age lady, and could barely got saved. Neither surgeon nor patient wants another surgery, and she had a big problem in here. So we could manage it, kind of. Luckily we could manage. Look at the scenario, look at the fixation, and they are not going ahead. One more screw would have been good enough right in the beginning, or maybe because they don't want to do it, because they want to keep this mobile. So but these things happen. These are known things, please understand. And this is another one patient which has got a fixation done. But beauty is, if you do endoscopically or least invisibly, you get less of these troubles coming. Now this is another thing we try to do with rags, but adhesions are so strong, sometimes they don't give in rather, in other words. And then that's where I devise my technique. I'm doing in a caudal way, the balloon neuroplasty. I'm putting balloon. Now remember, this is the ureteric balloon with the guide wire on, and I'm putting balloon there, and I've got a dye which is going inside. It can go up to the 30-40 psi. So that has to open up the adhesions, if there are any, for that matter. And this was done global first at that point of time through a white bore needle. And you see, I presented this paper, and I just show you the slide there. This is, it can go up, L4-5, we can take it up, we can bring it down, we can do it behind the disc sometime when doing endoscopic procedure. And this is just behind the vertebral body when I'm doing a fracture fixation. Sometime I keep this as a safety balloon. It can be done through caudal route, it can be done through transfemoral route, it can be done through endoscope. Like I've done endoscopy procedure. Now I want to see more on this. You see 50-50 or outside in approach. This is the area where you go in outside in, or in 50-50. Then you go inside, put a balloon up, and you want to be more satisfied. Okay, it's nicely done. Or through S1 foramina, like you're seeing in this route, and doing a procedure right from this area. This was presented in the World Congress in 2016. Professor Gore was there, and that is the epidural balloon neuroplasty and foraminoplasty, an innovation which was there. Now the last few slides is the caudal neuroplasty, and this is done. These Koreans are very, very smart. We keep doing talking and all, and they go ahead and do the commercial products ready. So I did a talk that time, and they have a product ready in few months. So this is the malleable ones. They have they can do the malleability, and they can do navigation inside, and they have a balloon also tipped now. Balloon tipped probes are there now, which can go inside. This is about the epiduroscopy. Well, it didn't took the test of time, and it's really, but I have a hope that with the good optics available, we might go back and do some good work with the epiduroscope, which is not really proving itself now. Yeah, this is not the laser. With the advent of laser, it is helping us one way, that if there is some cyst or some adhesions, we can really break. But taking disc, no, it is not. It is no for the disc thing. This can be combined with the PLD and SCLD sometime if required, or you can see if there's any migrated fragment. You really want to visualize what you're doing inside. You have visualized PLD, you can say that way. That is the advantage of it. And then you can really go and decompress. Last few slides. This is discal cyst, and you can really kind of de-roof this cyst. That's all. You go inside and just put a laser on, de-roof this, and this is done deal. The advanced pain therapies, which is already there in failed scenarios, like do a single lead or dual lead. But the beautiful thing which has come lately is, instead of putting the leads in here, they're putting next to the DRG, because here DRG is the powerhouse of the dermatome, and that's where the whole problem is lying, So they are addressing, and you're doing monoreticular pain, by the way, and especially in post-surgical scenarios, you just put on one route or the two routes for that matter, and that part is done. You don't have to do it whole spinal cord stimulation, because there is some problem with the tingling and all those paresthesia with the spinal cord stimulation. And what they have found is, if you do a spinal cord stimulation, the stimulation covers the whole leg, which is not really required. Patient has got a pain in here, and you do a DRG stimulation. The only targeted pain is knee pain or ankle pain can be taken care of. And they found the dorsal root procedures or reoperation or spinal cord stimulation, they found DRG is much better than all other procedures, which is even reop. Thank you for your time, sir. Thank you, sir. And this is about experience on cool RF versus thermal RF on facet arthropathy, keeping in view that total soft tissue trauma is produced and duration of pain relief. The answer is nicely put forth, and just can have a look at it. This is about this is the cool RF is slightly better than conventional RF, both in terms of effectivity and longevity. Because cool RF lesion is about 10 mm globular lesion, which is like a lollipop lesion, which goes like this is the cool tip. The lesion is like this, well ahead of the tip also. So you have to be very careful that when you put it on the bone, come retract slightly and then do your lesioning, because the lesion is going to be globular, which can go ahead of the tip. So it might burn the spinal nerve, that you have to be careful. Yes, the lesion is 10 mm, which is almost 2.5 times in the conventional RF lesion, which is the parallel lesion, palisade kind of lesion, which is right over this, right, like a kulfi stalk, or that lesion is there. So you have to be careful on that. For the conventional RF, you either have to do a bipolar lesion, or you have to put the bipolar or two lesions at the same facet. Now, the cool RF is of advantage when there is a very bad facet arthropathy and or post-surgical scenario where the facet nerve has got a variable course. So you don't know where exactly the variable nerve lying. The best thing in those scenarios is do a stim. Your stim always tells. I never believe in the radiology only. Your stim will tell. If you touch a nerve and you stimulate, that is going to pain and patient is going to cry. That's the place you burn the nerve. Do you give me a local and burn the nerve? Don't do it otherwise, because if you look at radiologically very good place and there is no stim response from the part of the patient, that means nerve is somewhere else, which you don't know. So what you see in your C-arm is a bony image, not the nerve per se. So that way, there's no image you can have. Even with the ultrasound, you see only the bones, not the nerve normally. Facet nerve being very small. The only best parameters is your stim, the sensory stim and the motor stim, and you really know it's not going down the leg, and that's the place you burn the nerve and you get the best response. That way, cool RF is slightly better, yes, in longevity as well as the effectivity, especially in difficult case scenarios. If you have a cool RF, good. It's costlier definitely, but if you have it, it's much better than having conventional RF. There are new things which is coming as a tripolar RF, which is already coming. So you will have those things coming down the line. But as of now, cool RF is the best. Combine the facet work along with the disc work, because patient will have a contribution in a chronic disc disease. Patient will surely have some contribution from the facet pain, and it becomes all the more eminent after the good surgery done, good disc surgery done, because there's going to be some collapse coming and there's going to be more of festogenic pain. So we don't want patient to come back crying with the pain again. So you do it in the same sitting or maybe a week or two after. It's a call. You can take that call. Yes, Sunny, you have a question, follow-up question, that the bigger lesion is justified in doing a damage, it might do the muscle damage. Normally it is said if it's a young patient only with facet arthropathy without any other disease process, you can do a conventional RF, which is more than enough. But if you fail again and again, or there is a bony anomaly or post-surgical scenario or difficult patients, in those patients only you look for cool RF. As far as nerve damage is concerned, definitely is going to be there, but muscle damage is less often because it's more a vascular thing. So it gets less damage, but yeah, we have to be careful on those accounts. But then you sit in the groove which is there at the memory ligament and try to burn nerve there. So normally you don't have all this soft tissue damage coming up. Yes, nerve is definitely going to be damaged. It's a fixed, it's a less vascular structure is going to be damaged.